And we're going to continue our medical theme today, which has been also recurring throughout the lecture series, with a session on digital technologies and algorithmic decision support in the medical field. And for that topic, it's my great pleasure to welcome Ulrike Feld. Ulrike Feld is professor of Science and Technology Studies. She's also the head of the Department of Science and Technology Studies. So those of you who are from that department will know her well. She's head of the research platform Responsible Research and Innovation in Academic Practice. And she's also a member of our own research platform, of course, Governing Digital Practices, which is the host or the organizer of this lecture series. And just very briefly on her background, Professor Feld has extensive experience in various national, international research projects. She worked at CERN for a couple of years. She held various visiting professorships around the world at various prestigious research institutions from Zurich to Harvard. And she's also regularly involved in developing and giving policy advice at the European level. In terms of her research interests, she's worked on the governance of science and science policy, changes in knowledge production, future visions, socio-technical infrastructures, and digitization. And across those areas, she has a strong focus on the natural sciences, I think, biomedicine, life sciences, environmental sciences, physics as well. The reading for today, by the way, is a recent article by Rike Thornholt and Henriette Langstrup, Between a Logic of Disruption and the Logic of Continuation, Negotiating the Legitimacy of Algorithms Used in Automated Clinical Decision-Making. And as always, that text is also available on Moodle. So as usual, the structure is we'll have Ulrike deliver the talk, and we'll have a Q&A at the end of the session. You'll be able to engage with the chat as well. Uli, it's great to have you. Thanks for joining us. Thanks for making the time as well today. And over to you, the floor is yours.
Today, I want to take you to the question of algorithmic decision-making in the medical field and kind of explore this question. I've given you one text, added one text to read. I will refer to that text and to some of the key tenets of the text within the lecture today, but I thought it might be a nice exemplary reading for how the authors argue about what it means to work with algorithms and with algorithmic decision-making. Now, let me get into medias res. Actually, medical systems over the recent years have expanded rapidly, also not only in complexity and technical sophistication, but also in costs. And we have a growing variety of treatment options. We collect more and more information due to also a number of digital tools that have been introduced. And therefore, the question of like, how can we improve decision-making processes is actually a very straightforward one that comes up in that context. So, and that is linked to actually the human limitation and the limited capacity to treat the sheer amount of data we are confronted with. And because we are also confronting a question of time in the medical system. So it's not that we could wait long and have a look and think, but very often in the medical field, decisions have to be taken relatively swiftly. And therefore, it is important to find ways of how to do so. And AI is becoming, therefore, increasingly relevant and quite widespread in the medical field. And in that sense, it becomes an important agent of change with regard to several things. The question of triage has been around, in particular, since we are in the middle of the pandemic and the pandemic crisis, where a lot of people started to think about why not delegating some of the triage phenomena to algorithms. Although this is rarely done in a straightforward manner, this was a kind of idea to maybe take away a bit of that enormous stress on people when having to decide who gets treated first, etc. Triage is not a new phenomenon neither. When there are big accidents or any of that kind, there is triage going on. You decide which one goes onto a helicopter and is brought to which hospital, etc., etc. So this is not totally new, but it is in times of crisis more important. Then the question of diagnosis and prognosis, which is even the more kind of the attractive part. And then, of course, also of treatment. In particular, as I said already in the beginning, we have many more potential treatments available than we had if we go back a couple of decades. Now, what is also important when we think about AI is this kind of socio-technical imaginary, this which it gravitates around. And by socio-technical imaginary, I think about, so how do we imagine our future carried out or realized through specific technological advances? And how do we share certain visions of what a good future would look like? And a good future in the healthcare system always means access to healthcare, relatively swift treatment of diseases, etc., etc. But it also comes with what I call in my work an economy of promise. So there are enormous amounts of promises how things will get better if we only rely sufficiently on certain technological means. We have witnessed over the past couple of years an emergent shared discourse on how AI will be pervasive in the medical field. And this discourse has the typical features of deep ambivalence between anxiety that AI will take over and that there will be kind of automated care systems put in place, etc., and hope on the other side that by being able to treat and work with more data than ever before, healthcare could actually become much better than it was so far. Now, we already have a number of successful applications of AI in medicine, and it's important to remind ourselves of that. For example, image diagnosis is already well in place, like X-rays, CAT scans, MRIs, and we arrive at a very high accuracy and speed that also goes hand in hand with the accuracy of images. And there are a number of cases where the AI can detect cancer in very early stages or see kind of changes in it at a moment in time when our capacity to see, so the visual capacities of medical professionals, is not yet capable or not capable to see these fine-grained differences. So there it is used widely, not without problems, because any algorithm needs a lot of human input before it can be an algorithm. And therefore, for example, we have to decide when is a cell counted as cancerogenous, for example. And depending where you set the limit, you might get false positive or false negative ones. And so this is a very important decision. It's very strongly used by now in dermatology. So to be able to match images of skin transformations that might be seen as hinting towards skin cancer or things, but also the automation of certain measurements that we have in diabetes or other diseases. You have already automated programs who survey your medical conditions. That has brought about the engagement of big tech companies that are in that business, like Microsoft, Google, or IBM, because of course, this is a kind of highly economically interesting field for these players. And therefore, this field is strongly kind of invaded by these actors. Now, we could also take an example of neonatal surveillance, which is something that is very strongly looked into, because in neonatal surveillance, we have the problem that the data we get from newborns that are so small and not yet stabilized, it's very difficult. And we have to combine many different measures in order to be able to make a decent diagnosis. And in fact, there's a high proportion of preterm infants that become infected while they are in the hospital. And that leads to a kind of significant mortality that is seen as evitable. And so there are, in a number of places, already AI-driven decision support systems in place that help, for example, to reduce sepsis risks, which is one of the big risks that you have. And what helps here is the real-time integration of physiological, clinical, and biological data of this little human being. And you see this here in the picture. And for example, the DigiNewB system developed in the Horizon 2020 program can identify, so the claim goes, sepsis 4 to 48 hours before any of the standard tests available or other approaches currently employed can do so. What does that mean? That means that we can start treatment 4 to 48 hours before actually we see the first signs. That means that we get the problem very early, and that in many cases, this leads to significant improvement in the success rates and therefore with lowering mortality rates. This is also important, for example, and used in certain hospitals in the COVID situation, where we can also see certain lung failures a bit earlier than one can see that with a kind of normal approaches to this condition. So we see that this is kind of widely kind of used and available, yet at the same, and very often in cases where we say the situation is desperate and this is better, this betters the situation significantly. Now, of course, in many ways, this has also backside, and I think this is an interesting case. I've taken that from the Washington Post. There was a kind of long report last February on that in America, a lot of investment has been made in AI baby monitors. And here the headline runs, AI baby monitors attract anxious parents. Fear is the quickest way to get people's attention. And so what they do is they have an advanced camera system, and they collect all kinds of visuals of the face of the baby and the way the baby breathes, and etc. The problem is that this starts to be what is often called hyper-monitoring and super surveillance, in the sense that every human being is irregular in many ways, so there is no constants. However, when we go for monitoring and with AI, we think we can kind of capture all the minor irregularities and do something about them. And this, of course, is not unproblematic. And as the text starts, say, baby monitor companies are pushing artificial intelligence technology into family nursery, promising that surveillance software is designed to record infants' faces, sounds, and movements can save them from injury or death. But medical, parenting, and privacy experts say the safety claims made for such internet-connected systems aren't supported by science and nearly prey on the fears of young parents to sell dubious technology. No federal agency has provided evidence to back them up. Now, this is already an interesting story here, because it ends with saying that no federal agency has provided evidence here. And this is also interesting because we see similar movements of data-driven apps for counseling in the medical field. And there, in order to make an app a medical device, so to really install it as something that gives medical advice and surveys medical conditions, this needs to go through a complex regulatory approving. So it turns an app into a technology that it has proven and needs clinical tests, etc., etc. So here we see a kind of differences, but I wanted to add that to show that, of course, AI related to medicine or health more generally is kind of expanding into a network in many different private arenas. Now, before I go into my case, I would like to make a short excursion, and I looked up what you have done already this semester. I think you shortly encountered Madeline Eckrich already. She's a researcher at the École de Mines in Paris, and was quite influential with her description of how we make technologies. And she points to the fact, and I need that for the argument around algorithms, she points to the fact that a large part of the work of innovators is that of inscribing a vision of or a prediction about the world in the technical content of the new object. So in our case, this means that developers of AI inscribe their vision of the problem and the health situation, the world, in the technical content of the new object. It will call the end product of this work, I will call the end product of this work a script or a scenario. And she continues to explain what a script for her is. Thus, like a film script, she says, technical objects define a framework of action together with the actors and the space in which they're supposed to act. So what she wants to say is actually that by developing AI and bringing that into the medical system, we have to understand several things. We have to first understand what is kind of scripted into the algorithm by the developers. Okay, so what is already part and parcel of the algorithm. Then in the second place, we have to look who are the actors around this algorithm. So doctors, patients, nurses, healthcare systems more generally. And then the space in which they are supposed to act. So is that a hospital? Is that the private space of my home where I'm on my own with my medical AI application, etc. And so what is also important, she then points to the fact that every technology comes, every new object comes with a geography of delegation between what is assumed by the technical object and the competences of other actors. And so as she thinks about, once you have, for example, an artificial intelligence technology in place, let me call it like that, then this redistributes the kind of roles. It delegates certain things to other actors. For example, if I have such a thing at home and I need to watch out for I invent now anything, my heart disease, then there is a responsibility delegated to me that I am competent enough to kind of know what the device tells me, if the device tells me something, so I can work with the feedback and by reading the numbers or by interpreting some scores that I know how to act. So this is a important element. So we have to keep in mind the scripts, the inscribing, and the geography of delegation. And then she continues, but says, of course, we have to go back and forth continually between the designers and the users. So between me as a patient using that or as a doctor and those who have made the algorithms. Between the designer's projected user, so the designer imagined me as a patient or imagined the doctor that had to take a decision, and the real user. Between the world inscribed in the object and how to so described by its of the object, and the world described by its displacement. So of course this is developed in a lab and then it moves into the hospital, and this is a displacement, and we have to think about that. For it is this incessant variation that we obtain access to the crucial relationship, the user's reactions that give body to the designer's project, and the way in which the user's real environment is the part specified by the introduction of a new piece of equipment. So we have to look at AI in use and not AI as an abstract imagined use. And I think that's the important point. Now I see I have a question here already. First question, what do you think a COVID-19 pandemic will encourage in any form a spread of implementation of AI technologies and algorithm in the medical field? And other question, how according to you implementation of AI and algorithms in medical field can support development, public healthcare system, etc. Actually, I would love to get a bit closer to that question at the end. This is a very good and very important question. Just a very quick answer to the first part. I think COVID-19 is but yet another driver of pushing AI. But for example, because there has been a lot of additional money. For example, there was a special AI call by the European Commission, and I'm part of a project that looks into telemedical care combined with AI in COVID-19 wards and how that could, for example, improve medical care. But there are zillions of other projects in that sense. So there have been special funding allocated because there's a strong belief that AI might kind of improve the oversight over many new cases and allow quicker reaction. But that would also be the case for many other fields. And the examples I will give you are much more, there are also much more mundane examples, like, for example, in the text that I have given you to read. But I'll come back to that a bit in the end. Now, so, okay, we describe. So as user, I integrate, and this object technological device is kind of displaced, and by integrating it into my world, I change the way it is, because it's my interaction that makes up the point. So we have to look at AI in use, actually. And unfortunately, many of the studies are more reflecting on AI in general and on data in general and on trust in general. And they're not really looking into the specificities of what that means for the work environments and how people develop a sense for data, for example, and a sense for working with AI, etc. And then finally, I need a little piece of Eckrich work for my argument. She continues to say, if most of the choices made by designers take the form of decisions about what should be delegated to whom or what, this means that technical objects contain and produce a specific geography of responsibilities. And I think this is a very important notion in my mind, because it says that the introduction of an AI device, for example, or an AI-based device, will also redistribute responsibilities. And I will specifically address that point. What does that mean when we bring AI-supported decision-making into the medical field? So how does that change? And that's why I wanted to introduce first, oops. Okay. Because the interesting point here is that we are confronted with two kinds of knowledge that is always, so AI versus the medical doctor. And this is a paper that appeared about 3-4 years ago, where this is discussed in a way, what happens when diagnosis is automated. This is the big debate. Can we automate diagnosis? And in which cases could we automate diagnosis? And then they make an interesting differentiation between two kinds of knowledge. The knowledge, the factual, propositional kind, so the knowing that, and the knowledge that is more implicit, experiential, and skill-based, that is the knowing how. And by making this differentiation between knowing that and knowing how, they point to the fact that algorithms can mainly cover only one kind of knowledge, namely the knowing that knowledge, and is less good, or even not very good in many cases, when it's about the more implicit, experiential, skill-based, the knowing how. And that's why a lot of analysts point to the fact that we will not move, or we will in most cases not move towards automated decision-making in the health field, because it's always about the conflict, the complex decision-making that involves the human in the loop in that sense. So this is Okay, now let's focus on the clinical decision support systems through AI. So let's start from from what I have outlined already and go to the clinic, the core of the medical healthcare systems. And I would say there are key questions that we have to address. What does the notion of support mean? And how will it shift with the implementation of AI over a longer period in time? So we have to think about the word of support in decision support system, because it doesn't say decision systems, it says decision support systems. The second is it raises the stakes of making AI transparent. So to open the black box of the algorithm. It is around trust relations, and therefore we have a lot of talk about trustworthy AI, and we have to address questions of responsibility. And these are the points I would like to touch on when it comes to clinical decision support systems. And of course, the big question behind all that is, will these decision support systems affect and transform the mode of interaction between different actors in the clinical environment? And that's an interesting point, because we generally think about doctor-patient relationships, but it's also, and that was an outcome of first interviews in hospitals, it's also a concern about the relation, for example, between nurses and doctors. Because if the belief is that with telemedicine combined with AI, you can do a lot of medical counseling at distance, this also lowers the interaction between different groups of personnel in the healthcare system, for example, nurses and doctors. And of course, this means also that you have a bit of a drifting apart of the social universes of these two groups, which has an impact also on the way how medical care is performed. So these are the kind of questions which I would like to explore with you in the following. So this immediately, and in the first place, opens up regulatory questions. And because AI decision support tools, as any medical software, has to comply with relevant standards. And this is obvious. To get a certification requires then clinical trials to demonstrate safety and efficacy. So it's not that AI simply has been introduced and some computer scientists have been playing around, but there have been a lot of discussion about which AI decision support tools should and could one introduce. And for example, if you go to the US, a medical device regulation by the Food and Drug Administration differentiates then between computer-aided detection. So like this picture I showed you above, where they showed the different kind of tissues or tissue. So tools that support diagnosis, but actively involve doctors in the process. For example, very often that is already in use, that, for example, relevant zones are highlighted by the computer or so, like you see here, that certain zones in this picture are colored specifically to attract the attention of the medical doctor. And then you have computer-aided diagnosis, and it aims providing an actionable diagnosis. So, for example, it goes and classifies a tumor as benign or malignant. Okay. That goes much further than the computer-aided detection, because the computer-aided detection is, if you want so, a kind of visual support that helps you to identify among many images certain kind of features, while the diagnosis then also speaks to these features. And then, of course, this has a number of different requirements. So when we speak about aided computer-aided or AI-aided medical support, it's really important to think about what does it mean? Is it about detection? Is it about diagnosis? And to kind of carefully think about these differences. Now, if we introduce AI in the clinic, there are, as you can easily imagine, a number of changes that are going on. It's kind of fascinating to see how through AI, the clinical work gets related to biomedical research, because there is no algorithm that has not fed in a lot of theoretical assumption about a specific medical field or a specific medical problem or a specific imaging, etc. So this is very research driven side, and so suddenly clinical diagnosing and treating gets closely related to biomedical research. So these two fields have become much closer entangled. AI has the capacity and the capability to discover and highlight correlations that might have otherwise escaped the attention of clinicians and researchers, for the simple reasons that as human beings, we have a limited capacity to treat the sheer amount of data, and therefore we might overlook certain things. Important thing is that correlations here, that of course not every correlation is a relevant correlation, and it's really up to the medical professionals to decide whether or not this is the case. So unlike the classical hypothesis-driven research, data or model-driven decision-making proceeds on the basis of AI processing large amounts of data and providing classifications of this data. However, and here comes the big however, we have no thorough understanding of very often when people use AI, they have no thorough understanding of the underlying mechanisms of the model. And this is very important and very interesting point. And I will come back to that later, because the more complex these models become, the less, as an outsider, you can understand what that means. And this is has become a specific profession, people who do these algorithms and work with artificial intelligence. And that's quite interesting that there is this gap, which I will come back, between the medical doctors and those who develop the AI stuff. So the clinicians, they deploy these tools, and decisions and actions taken get intertwined with the research and the development efforts of those people designing, calibrating, refining the support systems. And this is key, this key importance of transparency. Here I would like to refer to a very nice overview paper by Brown and co-authors from 2020, which give a very nice overview over the changes of AI in the clinics. Now, there are different kinds of relations and modes of interaction and meaning to the notion of support. And I have distinguished here 3 kinds, or in the literature, they distinguish 3 kinds. On the one point, the clinician interacts with AI. And this interaction can be situated in a spectrum of things, from supplementing the knowledge, know-how, and experiences of the medical doctor, on the one hand, so he just wants to have an add-on information by the AI, if you want to say so, to AI evaluating clinical information and making decisions. So there's a whole spectrum that goes from, oh, just give me some add-on information, to suggest me a decision, which is very, very different. Then the second one is clinician-patient interaction. And actually, AI sits in between them and delivers information for collective decision-making. However, this is a potentially quite complex situation for the patients of adding ever new information. So let's say the doctor told you something, and then you come up with an algorithmic image interpretation, and the algorithmic image interpretation says, oh, it's not that, it's this. And now this is extremely difficult, because even clinicians do not fully often grasp what the algorithm does. And so it becomes even more complicated for patients to get a full picture of what that is. And so this creates a kind of asymmetry, which is quite profound. and needs to be considered. So it's not straightforward. And finally, we have patient interact with AI. And this is very often in the context of their home, for example. In the article I've suggested for today's reading, this is actually the case where people have heart diseases or with diabetes or other diseases, that you have AI applications that allow you to stay home, and that through the algorithm, there's a decision made whether you need to be called in or whether you can stay at, be treated, if you want so, at distance. So in that case, the patient feeds AI with data and gets a recommendation. Now you're in a similar, the patient is a similar situation than the clinician is. I mean, do you blindly follow what the AI recommends you, which is generally assumed when you get these applications at home? Or is there something to be decided yourself or taken the responsibility for yourself, etc.? Now, let me go back to the first point, clinicians interacting with AI. And I find that a particular interesting and relevant point, because as a doctor, one of the important learnings and skills that you get during your education is actually to develop a kind of sensing, a feeling for a patient, that you do not only look at the numbers, but you look also at the patient. And by looking at the patient, you can decipher some of the health status of that person. Now, now AI comes in, and I am, let's say, a very experienced doctor. Then AI, it's very easy for me to take AI as an add-on information system. And I would take that on board in my decision, but I would not, it would really support my decision in the closest sense of the term, but it would not decide for me. What happens if I'm a very young doctor who has little to no experience and needs to take a decision? And then the decision support system tells me I would make this decision. I would take that choice. What would that mean for an unexperienced person to make that decision against the system, for example, or to follow the decision of the system and, for example, the patient dies? So this is the complexity of the issue at stake, is exactly how your experience as a doctor is related to the way how these algorithms are actually then used at the end of the day. And if you look down the row of these three interactions, you see that in each interaction, there is a challenge built in about how do we relate to that new form of knowledge that we get through algorithms, and through which we can kind of decide. Oops.
Uli, can I throw in a quick question
Yes.
on this? Would you say we've arrived with these AI systems at a stage where you have actively, as an MD, to justify a manual override? So this would actually be a step beyond already something being decision support. It would be a sort of decision authority almost, where you have to, if you deviate, you have to make an argument in a sense.
Yeah, that's a very good question. I mean, I don't think that we are there yet, but of course, this is a thin line, because how do you feel morally as a doctor about if you decide against following the recommendation of a system and your patient suffers then from something? This is not an uncomplex relationship. It's legally unclear, and there is a lot of discussion in the legal system. What does that mean for formal liability and responsibility? And does it lie at the end of the day? Is it distributed with the people who did the algorithm and you as a doctor, or is it only to you as a doctor? These are the big questions right now. I mean, we have had these cases and discussions even in the image recognition. They realized that when you calibrate the kind of algorithms, you need to tell the algorithm that from that level onwards, this a cell counts as cancer cell, for example. Mm-hmm. And depending where you put that level, you get a lot false positives or a lot false negatives. And this is an endless debate. Is it good to have so many false positives? Because even if you do afterwards, you take out some tissue, and so you do a biopsy. But of course, this is not innocent. I mean, this does something with people when you are told that there is there is an indication that you potentially have, for example, breast cancer. Mm-hmm. And that, of course, does something with patients. So it's not something that goes for free in a sense. And until you get clearance, a couple of days go by and you are living in this limbo, not knowing what's happening to you, etc. The same holds, of course, also for the false negatives, in the sense that depending where you put it. So I think this is actually one of the biggest challenges, I think, that lie ahead of AI in the medical field, is exactly to clarify what that means in terms of responsibility. Mm-hmm. And this is totally unclear. And not because it's only, I mean, we always think about the human in the loop still, but of course, this is right. But what does it mean if we more and more believe in AI? What is the moral pressure put on people to follow or not to follow is an interesting question, actually.
Right. So you could imagine a sort of trajectory where this goes into a direction where an MD is sort of like a pilot in the modern, I don't know, 777 Boeing, and they have to justify if they turn off the autopilot, and it's only in certain sort of quite specific situations that this would even be allowed, right?
Yeah, I'm wondering where we actually go with there, because some of the parts I have been describing a bit later on is actually exactly around how do we imagine the world? And in that sense, how do we imagine the healthcare system? And how do we imagine care? So, I mean, already now, if you think about some of these personalized assistants that people have on their mobile phones, I must confess I'm not very good at that, so I don't already listen to people, so I have difficulties listening to mobile phones, but that they get all these recommendations. You haven't done this today, you still need to do that today, and you haven't slept well tonight, and you still have to do this today, etc. And it's very interesting that people get gradually, some people get gradually addicted to that, and they kind of reorganize their lives along that. Now, it's very difficult to prove that this has negative impact on them. Mm-hmm. This is very difficult. I mean, it's not a deadly impact, but it might still have a psychological impact that is non-neglectable. So actually, I think it will be important also research in these areas to really carefully go away from looking at algorithms in this very abstract way and look really what it does in practice. And that's why I said it's really so important to not, I mean, it's good to have all these regulatory texts and to have these best practice things and all that, okay. But at the end of the day, the really challenging question will be how this reorganizes our everyday work and life. And I think that's for me, the interesting thing. And I mean, yesterday or today in the news, in the Euronews in the morning, there was this idea that you have an algorithm that composes out of, I don't know how many thousand paintings. He develops a known painting style. And then you can vote around that. And the algorithm is learning through this voting. And you can then buy this algorithmic produced unique pictures of something. And I saw one that was super Klimtian, but with a very strange touch. But it was very interesting to see what does that mean for art production, for example. Would we count that as art, or what is it? And kind of this is auctioned and people buy it. And I think it's very interesting to see how in so many different areas of life this enters. And of course, in art, we smile and we find it experimental, but we might find it less attractive if we don't know what happens to us when we go into the medical system, in particular when it's about serious diseases and not minor kind of issues.
Right. Thanks.
Okay, so let's now look a bit at the issues at stake. And the first issue and the most important one is, a very important one is this idea of opening the black box of the algorithm. AI and see what is in there. So transparency is one of these big calls. So because actually we take decisions, AI is generally used when decisions have to be made under complex conditions where there is scarce evidence and little time to take the decision. And the algorithm promises that he will be better than you are because he will be faster and can work on more information. So this is a baseline assumption that more information is better and that speed is crucial. However, there is this profound critique of the opacity of algorithms, in particular, when they start to work on the basis of artificial neural networks, because these artificial neural networks work in such a complex manner that if you are not the specialist in that, and if you haven't done it yourself, it's very hard to understand what's going on in that algorithm. So you can open the black box, but you can look into it and you don't understand what is happening in there. And then you have a number of dependencies. It depends enormously on the training data. Now, this is already very much debated when you look at facial recognition and the fact that there is a clear racial bias built into most of facial recognition. Now, this seems an obvious thing because we identify what racial bias is and we identify difference in race, etc. It becomes much more difficult when we look at training data for health conditions. Okay, we say, yeah, we should have gender, but I just want to remind you of cases we had not far in the past, maybe 15 years. There was a heart medication on the market that, and women that took that heart medication to avoid heart failures just simply died. Okay. And then when they started to invest, so the market was taken off the market, and when they started to investigate it, they realized the following. In none of the 3 steps every medication has to run through, any female candidates were part. So not female mice, but also no female patients or female citizens that have been trying out that medication. Now, what is special about women? They have a different hormonal household, if you want so, and that means that medication works differently. And so when giving this medication to women, this did not show the effects it showed in the men. We also know from medicine that depending on which ethnic groups you have in your trials, et cetera, all these things. So of course, you also have that with data. I mean, it's really very important to know which training data have been used. How special are they? Are they broad enough? Do they cover maybe the diversity that is needed to be covered and many more? What are the parameters that have been fed into that algorithms? What are the rules that tie different parameters together? What are the statistical calculations, etc.? And I could go on. Now, if that's a complex algorithm, it's virtually impossible to really understand it as an average kind of non-AI person. And so it's interesting that you have a rising asymmetries between patients and clinicians, because the one might understand it a bit better than the others. And of course, also between clinicians and AI. So it's not that the doctor knows, but the doctor is also confronted with many unknowns that he or she does not fully grasp what this algorithm does at the end of the day. So what about being able to assess biases, potential errors, et cetera, et cetera? So this is really one of the big issues. We speak about transparency. There is a lot of transparency argumentation going on, and transparency actually means that you deposit the algorithm. And a lot of people start to develop repositories for algorithms and trusted algorithms, etc. But at the end of the day, it is such a specialized field that it demands that you can hope that if it's transparent, it has also been checked and balanced by other colleagues who have an in-depth knowledge of the field, that they have done that, if you are not capable to do that. The second point is trustworthiness. And trust is one of the most complicated concepts, I personally find, as it's deeply relational. It's a deeply relational concept, and it's not a stable concept. It's something that is situational. So I trust certain people in certain situations, and now health situations are probably in our lives belong to the category of more vulnerable situations. And so trust is something that is already a complex animal. In normal healthcare situations, it gets more complicated even. So trustworthiness demands a specific kind of risk-benefit analysis. So does an AI and does an algorithm really improve anything significantly, or does it just hides or make invisible certain choices? Does it improve care options without losing the doctor-patient interaction? Or is it actually made, because it very often comes in connection with the fact that medical systems are too expensive, and that would be one way of saving us. And so in the paper I gave you to read, it's an interesting case that the algorithm decides who needs to see the doctor and who can stay home and do that on their own, okay? So this makes, changes the doctor-patient interaction. Leave the final decision with human actors is very often still the kind of claim that an algorithm trustworthiness also builds on the fact that it doesn't force the human to make this choice. But as we just discussed with Lucas, the question is, I mean, choice is always also a situated concept, and might be more difficult depending on your situation and on the case and on the pressure under which you are, etc. It's not for nothing that we discuss triage under stress situations through algorithms, because it is so stressful and so oppressing for people to do these kinds of choices. Then it's about data protection, because algorithms have to be fed by a lot of data, and it has to be clear where these data go and how they are used, etc., etc. We have to regulate AI, means finding legal framings related to the risk they run, and that also picks up some of the points I already made. And of course, it comes with the question of responsibility distribution, what I mentioned already when I spoke about Eckrich idea that every technology brings along a geography of responsibility. Then we have to really ask ourselves in each specific context, how is for that application the geography of responsibility actually mapped out? So who is responsible for whom to make what kind of decision, etc., etc. And that is, and then I come directly to the responsibility. So who is involved in decision making, and what role does AI get there? And it's unclear who morally, it makes unclear who is morally and legally responsible. And I want to differentiate that, because responsibility is not only reduced to legal responsibility. Making a job and having to work with people's health, around people's health, is a very responsible profession. And in particular, when it's about making choices about people's lives, then it becomes even more morally also important to think about that. And legally, it's kind of interesting. So what counts then as a proof for misconduct? And this is a kind of worry that is the elephant in the room in many of the discussions. So can I come and say, I got badly, my treatment was not adequate, and actually I know that the doctor had a different recommendation, and can I then sue the doctor? This is maybe in Austria not such a case, because suing a doctor in the Austrian context is not something that happens very often, but it is a point that we have to take into consideration depending on the cultural context. These concerns are very present in the public debate around AI, actually. And as I made this differentiation already, it plays out differently, responsibility plays out differently in different situations. So if it's the doctor in AI, then you have a partial shift of responsibility for diagnosis, recommendation, and decision-making. yes and no, because does the medical system foresee that the doctor makes the final decision? Then AI does not really take responsibility, or people behind AI do not take responsibility. If it's about doctor-patient relationship, we have to think about new forms of responsibility as the doctor is, or as the patient is facing an increased informational asymmetry due to AI. So the doctor knows very differently, even more differently than the patient, than it's under normal circumstances. So that makes the relation also the responsibility in this relation a bit more complex. And of course, patient and AI, I think this is a very interesting question, because in many ways, the prevalent paternalism that we always complain about in the medical system is replaced by new forms of individual choice, pretended individual choice, which, however, rests on a lack of access to key insights into AI. So I have then to rely on my AI tool telling me I have to do this or that. And then the question of, is that a new technological paternalism, or what is that? And I think this is just interesting to reflect about that, and to think how that changes our idea of relationships. Now, there is a lot of this discussion about how AI is revolutionizing and making things different, etc., and that this is a new era. And if you read all these European policy documents, you might think that this is really something super fundamental. But what I like in the paper by Thornholt and Langstrup, which I gave you as an accompanying literature, is that they ask a really interesting question. They say there is a tendency that you have two logics present. You have a logic of disruption and a logic of continuation. And they want to move away from focusing solely on the logic of disruption and also look into the logic of continuation. And as I said already before, I find it interesting that certain features that are problematic in the use of AI have also been problematic in former structures of the healthcare system. And in that sense, it is important to reflect that. And when they say logic, they use Moll's concept of logic, which does not mean stable coherence, and it's not obvious. So there's no obvious logic. And she underlines it may be embedded in practices, buildings, habits, and machines. And it's not something it's not a kind of basic human rationality, which we all agree on that it works like that. So don't understand logic in that way, but understand it much more as situated and embedded in the way we do things, etc. And in their paper, they explore how algorithms for clinical decision-making are enacted by political stakeholders, healthcare professionals, and patients. And I find this really interesting because it gives us this flavor of how this is practiced in the different realms and how it's done. And it investigates how the legitimacy of delegating decision to an algorithm is actually negotiated. And this is what I personally find probably the most interesting facet in that paper. Now let's delve a bit into that. They describe the situation in which we find ourselves as one that is caught between disruption and continuity. Disruption, because there is a load of literature, and in particular in the social sciences, that have spoken about how the datafication of health changes our vision of health, how the whole talk on the digital revolution. And then digitization of healthcare is often described with vocabulary as fundamentally different, revolutionary, and as also disruptive. For example, Deborah Lupton, or many, many others. I could kind of, and in the article you find loads of different ways to point to make the exceptionality argument. And what I find so nice that the authors then say, yeah, okay, there might be this disruptive part, but actually to understand AI really and what it does, we also need to look at the continuity. And here the authors start to point out that actually algorithms are far from stable and perfect. And there's a lot of investment needed to make them work in everyday environments, both in their case, but it's also interesting to see that in the healthcare system, that there is always something to repair, to rethink, to reconceptualize, to recalibrate, so the reing of everything, so rethink, recalibrate, etc., in order to make AI, to stabilize AI, that needs to be continuously kind of learning in that sense. And Dorenholt and Langstrup then argue that algorithms have actually a long prehistory. And I think I had a short look at some of the slides, and I think you had already a more historical unit where you looked into how algorithms were also kind of manually performed, if you want so. And they make this argument very clearly, and they say, actually, algorithms and algorithmic thinking has a long prehistory in medicine. In particular, for example, everything that goes with standardizing tools like protocols, clinical guidelines. We want to have a routinized way of dealing with things, one step after the other. And an algorithm is nothing more than that. It can just do that with many, many more things at the same time and many, many more data points at the same time. You have standardized and digitized expert systems that are not necessarily, that were the precursors of algorithms. And we have the delegation of agency also in more manual, in more kind of classical ways. For example, let's follow the protocol. The protocol is a prescribed way of doing things. And doctors might ask themselves in some cases if that's the best way, but you know that in many ways you have to follow the protocol. And we also know that in certain health conditions, this has also caused severe difficulties. And we have seen part of that debate just scratching on the surface. Along the development of the COVID-19, we have realized that in many cases we too early intubated people and gave them, and the intubation actually for a moment often sometimes worsened their case. So there was this whole discussion, when is a good moment to just oxygenate somebody or to intubate somebody. But there are protocols in place, and the question is like, how standardized are they, and et cetera, et cetera. And actually, algorithms, like infrastructures, algorithms build on pre-existing practices, on pre-existing routines, and they do never come totally new. And that's, I think, the interesting element is, however, that the scaling up creates also new qualitative elements, and I think that's maybe the important point to retain from that. Now, in their case, they look at the introduction of the so-called Pro Tools in Denmark. And so, and they show how the discourse was. And when they did the test cases for that, so when they did a study whether this is good, so these are AI-related tools that people get when they get home with certain diseases. It's interesting to see they point at the fact that there's a discourse of that the algorithms disrupt inefficient human work. They become more efficient. So they are disruptive, but in a positive sense. So there is a clear discourse on improvement through algorithms. So there is this imagination and this promise. So you have an in their case, they have an automated triage system, but now the triage system has as a goal, to decide who needs a doctor's interaction and should be called into the doctor's office, looking at the values, et cetera, and the behavior, and who gets an automated message that they have been fine, or a phone call. And the idea is really here very strongly pushed by financial means. Okay, so saving. Now, the interesting thing here they observe, which made me smile a bit, to be honest, was that when they translate the policy study into the implementation, they never speak about automated triage, or they don't speak about this ineffective work. They speak of the positive things that will be changing. They speak of systematic and efficient patient involvement. So this fits very nicely with the patient empowerment discourse. And so they tell people that this tool, this AI tool at home, will allow systematic and efficient patient involvement. And at the same time, you have, it's not much difference discourse. So it's just better. It's not fundamentally different, it's just better. So it's just more data and quicker and easier. And so it has all these kind of positive connotations. And in that sense, the promise is that the doctor is already in the algorithms. So all the know-how of the doctor has gone into the development of these algorithms. And therefore, it's not that the doctor is out of the loop, but the doctor is still in the loop, etc. So here we see already that this translation from the policy space to the public space has totally different discourses of reasoning built around it, and needs different work to convince people to kind of engage with that practice. Okay, now I don't want to go further into the detail of that study, because I think it will be nice maybe if you have pleasure to read it. I want to conclude today's presentation by a couple of reflections. The first is that I think it's important to look at the tensions and pretensions. So what do we pretend that AI actually is as a support, as a decision support tool? What do we imagine AI can do? How do we imagine the social processes of healthcare? And what are the points that remain unaddressed? So we speak about transparency, we speak about trustworthiness. These are the two vocabularies that are most publicly named as important. And of course, data protection, that is always added everywhere by now. However, we hear much less about the legal situation, about the question of who is responsible for what, etc. And am I, for example, as patient responsible then when I'm at home, if I do not follow what the AI suggestions, am I then responsible for my healthcare situation, or what is it? Yeah. So the question of these, we have to ask ourselves what is new, and be very attentive to what is new. And the new can very often come through a gradual change and not through a revolutionary change. So we have to think about how quantity, for example, of images, or how speed kind of changes then relationships. So the new is not the treatment of images and the combination, it's the kind of sheer amount of things you can combine, etc. And where should we start with our questioning of change? And I think this, for me, this is very clear, that it is more at the practice end, that we need to delve deeper and better understand how algorithms work in practice, or how we work with algorithms, or how algorithms work with us, etc. Algorithmic decision support systems is a field of constant change, and it's extending in ever more areas, from the core of the medical system to many other domains. And actually, recommender systems are the more primitive versions of these decision support systems, because actually they make you so many suggestions and so regularly that they want to kind of incite you to kind of, or incite you, sorry, to kind of take certain features. Now, this is not related to health or anything like that, but it's a quite interesting question of like where this has this pervaded to. And that's why I took the example of the baby surveillance. So how much of that is actually really improving a condition? How much of that is actually making it even more complex? And finally, I think it's really important to look at algorithms and AI as ordering devices with unclear responsibility relations. And this is also a question which I think needs to be explored, because it's not only about legal responsibility. I do think it's as important to think about social and moral responsibility in order to better understand that. And that's where I would like to stop today. And I thank you for your attention.